I'm Renato Lopes, Professor of Medicine at Duke University. I wanted to welcome to this deep dive session. Here we are at the ESC TV, directly from Barcelona, where we're going to be deep diving into what I consider the most important trial of the meeting. And Karthik, I'm here with you. You just presented the INVICTUS trial. Why don't we just start just by summarizing the main results, because I confess I still have to hear one more time to believe, and it's important that everybody's on the same page.
Thank you, Renato. Yeah, it was something which was quite unexpected, but I think in a nice way. INVICTUS is an international open-label non-inferiority randomized controlled trial which was done in mainly developing countries, because we included a population which is rheumatic heart disease, which is found in RHD endemic countries in Africa and South Asia mainly, and Latin America as well. So what we did was as we all know, there is no evidence for anticoagulation in patients with rheumatic valvular heart disease and atrial fibrillation. All these patients were unfortunately excluded from the earlier trials. It's very challenging to maintain INRs in these patients, and we thought that it would be a good idea to look at an anticoagulant which does not require monitoring. So we used rivaroxaban here, and so we compared rivaroxaban 20 mg at the usual dose that's been used in non-valvular AF, and compared it with any locally approved vitamin K antagonist. It was 85% warfarin most of the time, and in some countries they used acinocumarol as well. So our primary outcome was a composite outcome, which was stroke, systemic embolism, myocardial infarction, and death due to vascular and unknown causes. And at the end of 3.1 years of follow-up, we found, to our surprise, that rivaroxaban increased the risk of the primary outcome by about 25%. And this increase was largely driven by what we think is a reduction in mortality seen in the VKA arm. We also found a signal for a reduction in ischemic stroke, although the overall outcome of stroke versus stroke and systemic embolism was not different. The ischemic stroke rates were different, but the numbers were much smaller. The good thing was both the anticoagulants were quite safe. There was no major bleeding, and there was no major bleeding difference between the two arms. So in effect, it cements the role of VKAs in rheumatic atrial fibrillation. So that's in brief, and there are several aspects which are quite interesting, and we can discuss that.
No, that's fantastic, because as everybody remember, and we discussed today, this is a population that was not included in the NOAC trials. Again, we had to go with the same population of the warfarin control placebo trials that were done in the early 90s. And we did the trials with NOACs. We proved it works. They are a better option than warfarin, but this was still a gap. We still did not have the answer. Can we use NOACs in patients with primarily mitral stenosis, moderate to severe? A lot of people were using off-label.
Yes,
right?
Yes. But a lot of people in, I think, even Latin America and South Asia for sure, were using direct oral anticoagulants off-labels.
Correct. And we didn't have a so easy and clear biological plausibility to really think that the NOACs would not work in this particular scenario. But again, this is one of, to me, the most important lesson learned, which is that's why we need and do trials, because guessing in medicine doesn't help. So you guys should be congratulated. You go there, do the trial, large trial, and show the opposite. Very surprising, show that warfarin is a better option, and warfarin beats the NOAC in this case. Of course, this happened after 2 years. In the beginning, they were almost in the opposite direction, almost a benefit for rivaroxaban compared to warfarin. But then after 2 years, you were able to bring the TTR to a really good control, and then warfarin takes over in terms of benefits. Tell us a little bit about how did you manage to control the INR so well in countries that we know are so challenging?
That's I think the big takeaway should be that for people practicing in developing countries. So as you know, our INR in range is usually about 33% in most developing countries. So at the beginning of the trial, because this is a non-inferiority trial, we needed to be absolutely sure that our control arm was treated well. So we had an algorithm which looked at increasing or decreasing dose by about 10%, so weekly dose by 10%, and we implemented it very rigorously. So everybody was given training, and we started this about 6 months into the trial, and then we can see the effects within by about 2 years. All our the proportion of INRs in range increased to about 65%. So this was a simple algorithm, and algorithms are not generally used in our countries. For example, in India, nobody uses algorithms so far. But I think this was a way of introducing people to using algorithms rather than just using intuitive dose management. So I think this was a good lesson in that, and we were able to achieve INRs in range which was in line with the previous DOAC trials, which were largely done in high-income countries. So I think that's the big takeaway from this.
And Karthik, tell me something. It's an open-label study, and we know the difficulties of doing a double-blind study when you have a warfarin comparator, because you're going to have to create now sham INRs, and it's very complicated and very costly. So you did the open label study, but there are issues with that design. Do you think that the nature of the trial being open label could have affected your results? And also, because you had such a good INR, I'm assuming that these patients were seen much more frequently than patients receiving rivaroxaban. So could also this be a marker of a general better care of these patients using warfarin, because they're seeing more often? I know there are not a lot of hypertension patients, but maybe there were more adjustment of hypertension drugs, or you're just touching base with patients to see what was going on. How much this played out in your finding, striking finding, of the benefits of warfarin compared to rivaroxaban?
That's been plaguing our discussions when we saw the results. So we discussed this at length. So let's look at the broad picture. The first thing is that the reduction in mortality was huge. It was 25% reduction in mortality, which contributed to about 1.5% reduction per year over the duration of the study. This is a large difference. Now, if we were to look at prior literature in patients with HFrEF or HFpEF, there is very little data to suggest that frequent contact improves outcomes to this extent. So that being said, definitely because of the open label design, patients in the VK arm often met either their coordinators or study coordinators, in some cases even cardiologists in some parts of the world. This could have had an impact, but we believe that it probably cannot account for all the difference that we are seeing, for several reasons. The number one reason is that we did not find any difference in heart failure medications between the two arms. So that was, I think, an important finding. The second thing is we also did not see any increases in heart failure hospitalizations, differences in heart failure hospitalizations between the two groups, and neither was there a difference in valve replacement, need for valve replacement or valvuloplasty between the two groups. So it is possible that this contributed to some better care, but I'm not sure that it can account for all the difference that we are seeing. So there is something going on here which we need to explore. I mean, anything is speculation at the moment, but we can't obviously ignore the open label design and whatever disadvantages it brings.
Yeah, that's fascinating. And if you think about it, it's not the first time in this field that we've seen this increase in mortality with NOACs. If you remember the Galileo study, of course, different comparator, different scenario, TAVR, but we also found patients without AFib, higher mortality with rivaroxaban, which we cannot explain until today. We try to look at different ways, and there are no explanations for that. So I think you have a lot of work, you and your team, to look at that.
Yes.
But just to wrap up the mortality piece, these people, as you said, it's a big difference in mortality, drove your primary results, but the difference is not being driven by stroke and is not being driven by bleeding. So the question is, what are these patients dying from? Because they are 50 years of age, they are 70% female, the classic rheumatic patients that we see every day. What are these patients dying from?
So broadly, we had about 990 odd deaths in INVICTUS, and about 700 odd of them, which is about 80% of them, were either vascular deaths. So they were either heart failure deaths or what we classified as sudden deaths. So 80% of all mortality was vascular mortality, mostly driven by heart failure mortality or sudden death mortality. So that was the primary driver. So which brings us to the question of how warfarin could have affected this mortality. So that's a conundrum. We really don't know. So we need to explore that, keeping in mind that it could have been the increased care, improved care, and all those things.
So patients were dying from heart failure, adjudicated, I presume, but not necessarily having heart failure events to differentiate between the two arms. Is that correct?
Right. So there is a I think all of us know that in heart failure trials done in high-income countries, usually the ratio of heart failure hospitalization to deaths is about 3-to-1 or 4-to-1. Whereas typically in developing countries, this ratio is more like 1-to-1. So, which is what we found also. So we found the number of deaths is around the same as the number of heart failure hospitalizations. So heart failure hospitalization is a very insensitive measure. This is a lesson we are learning. So we need to include a more broad definition of heart failure worsening if we have to do trials in developing countries to capture this outcome, because most people can't get to hospital, or there is a capacity issue in terms of hospital admission.
But did you find a difference between hospitalization and...
No, we did not.
No difference.
We did not.
Perfect. So the other point that it caught my attention is that not every mitral stenosis was moderate and severe. It seems that based on some of the definition, you include between valve area from 1.5 to 2, which in some places would be considered a mild mitral stenosis, not the real moderate and severe mitral stenosis. And on the other hand, about 18% of patients did not even have mitral stenosis at all. Is that correct?
No, 85% of patients had mitral stenosis. And of these 85%, about two-thirds, 66%, had severe mitral stenosis, which is by definition a valve area less than or equal to 1.5. The current definition of severe mitral stenosis by the ACC/AHA is what we are considering. So most patients had mitral stenosis. The only other way you could get into the trial is that if you didn't have mitral stenosis, that you had to have a high CHA2DS2-VASc score. So that's that is about 15% of people. So
correct, but the 15% that did not have mitral stenosis, they had to have rheumatic heart disease.
Correct.
So how was that defined? Can you remind everyone how was that defined?
So rheumatic heart disease for people who practice in developing countries is pretty straightforward. So we are looking at a subset of patients who have advanced disease, and advanced valvular disease is very easy to identify. There are really no differential diagnosis for patients with rheumatic heart disease when it is so advanced. We don't need to use any criteria. There are very typical features, involvement of the mitral valve, PML restriction, some AML doming, mitral regurgitation, thickening, subvalvular deformity, things like that. So it's pretty straightforward.
And did you find a treatment effect, differentiation treatment effect based on the severity of the mitral stenosis or the valve area of the mitral stenosis?
So we had a set of pre-specified subgroups, one of which was the severity of mitral stenosis. So we did not find any difference between the effect of rivaroxaban versus VKA in these different subgroups. So it did not matter if either the patient had mitral stenosis or did not have mitral stenosis, or depending on even severity of mitral stenosis, the effect was the same. So it was preserved across subgroups.
I have so many more questions, but does anyone have any question? Please.
Thank you. What about patients with labile ANR? Did you study the benefits of of rivaroxaban in these patients?
What was the question?
INR that are swinging. The TTR where the TTR is not good. This is subgroup. Did you study the difference?
Oh, according to, I think, if I understood, you're asking if there was any treatment effect based on TTR variation. So did you see if these results were the same, irrespective of the TTR being well controlled or not?
Okay, so so the INR control is post baseline, so it's strictly not a baseline comparison. It's not a subgroup analysis. We looked at INR quintiles by centers.
Correct.
It tended to be it tended towards improvement in INR, but that is really a effect of treatment. So it's not really a subgroup analysis. This is to be expected, although it was not statistically significant by center when we looked at it by center. But it really is not informative in that sense. You do expect that when people have a better INR, they will have better outcomes in terms of stroke and ischemic outcomes.
We know that some proportion, whatever we do, some proportion of patients will have always an INR high or low.
You mean labile INRs is what you're saying? Labile INRs, INRs not
Yes.
So we did not specifically look at it that way, but I'm sure there were some patients like that.
It
but
will be that's in these patients perhaps rivaroxaban will work as the same or better. No.
I wouldn't know. I mean, that would be speculation.
Yeah.
For now, I think we should take the overall results of the trial, which shows clearly that VKAs are better. So.
Correct.
Okay.
Good. One more question.
Hi. I was asking if in this area anybody was subgrouping for the vaccine of COVID in this part of the study?
Yes, a large part of the trial was spent during the pandemic, and in many countries vaccination was in force. So India, for example, Brazil, and large parts of Africa as well. South Africa was almost.
So in the subgrouping of the patient who had sudden case of mortality, was there any kind of data about what kind of vaccine or something? Is there any kind of that maybe interaction of?
No, we didn't look at it. We expect that in a randomized trial, vaccinations would have been similar in both arms, and if anything happened, it would have happened similarly in both arms. But we haven't looked at it that way.
I'm Swati Mukherjee. I'm an interventional cardiologist from Melbourne. I just had a quick question with my interest in women and heart disease. If large part of the deaths were from heart failure, do you think the frequent visits that the INR, the VKA arm got, that made a difference in mortality? Do you have any thoughts on that?
Yeah, so that's what we were discussing in the beginning. So it is possible that impacted outcomes in a way, in a favorable way, but the difference in outcomes is so large that it makes it a little unreasonable to expect that all of it was because of that. And we also had some indicators that there was no difference in heart failure medication between the two arms, and we did not find any differences in heart failure hospitalizations or the need for valve replacement or valvuloplasty. So that makes all this assumption as being very important a little unlikely, but it could definitely have contributed to a difference. But the difference was very large, so it's very difficult to attribute everything to just one.
We think that it is likely arrhythmogenic. Is that the idea behind?
So I think heart failure, a large proportion of deaths in patients with heart failure is sudden. So I think this is not very different from any other heart failure in that sense. So many of these patients, so the definition of sudden cardiac death that we used for adjudicating them was any death within 24 hours. So patients were in heart failure. You will see that about 40% of patients were already in heart failure. So this is expected. This is to be expected. So it is not an unreasonable proportion of sudden deaths.
So
Now, just one further question. The INR control that you saw in your trial is, as you said, nothing like real world in India. How are we going to take these trial data back to the real world?
I think the most important lesson that we learned is to use an algorithm, encourage the use of an algorithm. Like I said, we don't use algorithms in general. So I think the simple step is to use an algorithm, encourage the use of an algorithm, and we achieved a good INR.
Thank you.
Thank you, everyone. I think we are in the top of the hour. I'm sure that you can catch up with him after. Karthik will be happy, I think, to answer a little bit more, a few more questions. Again, congratulations to you and your team. This is a field where we desperately need randomized trial, and I think you beautifully illustrate why we do trials and why we need trials to drive practice. So thank you very much.
Thank you. Thank you.